on knee osteoarthritis pain flares, particularly some work done in Sri Lanka. And this is the outline of my talk. I will describe the disease burden due to knee osteoarthritis and then explain the place of our research, local research on pathogenesis and treatment of the condition. I will then explain why it is important to understand knee osteoarthritis pain flares and describe how we examine three research questions. The first being, what are the risk factors for knee OA pain flares? Can a prediction model be developed to predict pain flares? And can we identify pain trajectories in early knee osteoarthritis? And I will conclude giving some implications for clinical research and practice. So, why is it important for us to know about knee osteoarthritis or knee osteoarthritis pain flares? Osteoarthritis is the commonest joint disease in the world, and it is a global health problem. Actually, it is now our problem. It is common in South Asia with a high prevalence and a high incidence, and large numbers of our patients are living with increasing disability and increased number of years. The estimates have risen, and if global statistics will be applicable here, 1 in 8 people will develop the symptoms of osteoarthritis during their lifetime. Knee osteoarthritis accounts for 80% of the global disease burden, and that is also rising due to increased risk factors, and it's going to rise further. And if this room had only 75-year-olds, more than 1 in 3 of them will have symptomatic knee osteoarthritis. It is fortunate that we have moved beyond the old understanding of knee osteoarthritis, and it is not necessarily believed to be a disease of wear and tear of cartilage. It is believed to be a multifactorial whole joint disease that is due to an imbalance between joint tissue repair and destruction. In fact, metabolic, inflammatory, and mechanical factors mediate cartilage degradation, osteophyte formation, subchondral bone remodeling, and synovitis and synovial inflammation. Inflammation seems to be very important in osteoarthritis, and our research from a large cohort of patients from the Osteoarthritis Initiative showed that having features of inflammation or synovitis on MRI predicted the occurrence of knee osteoarthritis. Our research from Sri Lanka revealed that there is an elevation of cytokines in both primary and secondary osteoarthritis compared to controls. And in fact, there was a subtle difference in the serum cytokine ratios in secondary osteoarthritis, which has a higher Th1 to Th2 profile than primary osteoarthritis. Though the understanding of osteoarthritis has improved, the treatment is still focused on weight loss, exercise, and non-steroidal anti-inflammatory agents, and these are particularly challenging in older people who have multimorbidity and osteoarthritis. But comprehensive multidisciplinary care works, and our research from the Osteoarthritis Chronic Care Program, this is in Sydney, showed that improvement in pain and physical function occurred in people who underwent non-surgical management protocols, and this was irrespective of their radiographic changes on X-ray. So even people with end-stage radiographic knee osteoarthritis can respond to non-surgical management. This is difficult in our South Asian setting where we don't have money for multidisciplinary clinics and to accommodate physiotherapists, rheumatologists, occupational therapists, and nutritionists all under one roof in high budget clinics. And weight loss is particularly challenging because we need approximately 7% weight loss for a significant clinical improvement. This is tough in older people, but it is very difficult in South Asia, where we have recently transitioned from an agricultural society, and we have really not modified our diet adequately to manage our newer energy expenditure. Also, we don't have a good substitute to replace the high amounts of physical activity in agricultural work. And we are now becoming more sedentary and stuck to the same diet and the same level of exercise which we would have managed with perfectly fine if we were doing agricultural work. Also, there are some social and cultural issues which limit physical activity, particularly in women who have osteoarthritis more commonly. We South Asians in general have a higher body fat, lower skeletal mass for a given body mass index compared to our Western counterparts. So, this also has potential to adversely affect knee osteoarthritis progression. So, established knee osteoarthritis is difficult to treat for us in South Asia particularly, and it is essentially still a disease without a cure. And the impact of pain is profound, but it is useful that the structural determinants on radiographs are really not the only determinants of pain. There are psychosocial comorbidities and socio-economic circumstances which also impact pain in osteoarthritis. So, though it is a leading cause of disability in us and older people, we now understand it to be a chronic symptomatic pain disorder which is made worse by acute episodes of severe intermittent pain. And these acute episodes are generally characterized by worsening of the knee pain with knee inflammation, synovitis and effusion. In our studies of Sri Lankans, and we are similar to you very much, I think. So we had a high estimate of clinical knee osteoarthritis, and in our patients who have lesser duration of knee osteoarthritis, 54% reported pain flares, episodes of pain which were disabling, and they had 1.7 pain flares per month. Pain flares are supposed to be a phenomenon of early osteoarthritis, and experts postulate that these acute intermittent pain flares in knee osteoarthritis drive the underlying disease process. Initially, these pain flares settle without causing joint damage, but as time goes on, they become longer, more often, and then progress in frequency, intensity, and duration, causing chronic joint failure. Therefore, it's important that we understand what is going on in knee osteoarthritis pain flares, and the rest of my lecture will focus on 3 projects independently done to examine the risk factors for knee osteoarthritis flares and trying to develop a multivariable clinical prediction model, and try also to understand whether there are knee OA pain trajectories in early osteoarthritis. We had 3 different statistical methods to examine these 3 questions, and we used a case crossover study design using conditional logistic regression to understand who is at high risk of flares. We used a multivariable regression model, logistic regression model, to predict flares, and we used a statistical technique called latent class growth analysis to identify those in whom knee OA pain progresses early. Our original intent was to have 2 groups of patients, one in Australia, one in Sri Lanka, and to examine these patients over time and to compare the 2 different groups who are in the APLA region but very, very socio-economically different. The Australian cohort, we collected data by web because they are very internet using people, and they had more than 92% of them are internet using. But in Sri Lanka, like in other parts of South Asia, internet use is less. Particularly in Sri Lanka, it is 35%, but most of us own phones, so we use a telephone-based data collection method. What is interesting again here is that our patients had more pain flares than the Australian people. And we also didn't continue follow-up. Our patients didn't continue follow-up as much as the Australians. So part of the reason I think for the pain flares is that the duration of pain in our cohort is much less than the Australians. And also our patients continue to have more knee buckling and were also barefoot compared to the Australians. So what were the risk factors associated with knee OA flares? And we wanted to do this study because we could use these risk factors for patient education as well as to examine these risk factors in clinical trials, particularly those with flare-related endpoints. And we used a case crossover study design, which is a relatively new design, and it might be useful for you because it enables us to study smaller cohorts of patients. And it's very useful for us to examine short-lasting triggers which cause unpredictable events, and it's perfect to study acute exacerbations of chronic diseases. We use the case points as the point of any knee OA pain flares, and everybody was studied every 10 days, and those were our control points. So the same person was compared during case and control points. We examined multiple risk factors: knee buckling, knee injury, physical activity, footwear, being barefoot, sleep, and mood scales. And we used something called a hazard period, which is the time from risk factor to insult. And that was dependent on previous literature. As I explained earlier, the associations were examined by conditional logistic regression. We found that the following mechanical insults increase the odds of knee osteoarthritis pain flares, namely knee injury, buckling, increased duration of using footwear, and increasing physical activity. But we also found, and this may be relevant to you, that being barefoot reduces the odds of knee osteoarthritis pain flares. Certain mood subscales like being afraid, scared, or upset increase pain in knee OA pain flares, while increased sleep reduce knee OA pain flares. And for the sake of time, I will show that the odds ratios or the strengths of the association were similar in the Australian cohort as well as in the Sri Lankan cohort. We examined physical activity in the Sri Lankan cohort, being barefoot and wearing footwear, and we finally concluded that risk factors which have a potential to reduce pain thresholds like negative mood, reduced sleep, increased pain flares, and that any insult to the knee caused knee OA flares by mediating synovial inflammation. So if you have an injury or an insult into a synovial joint, there is inflammation which causes pain, which releases pain-causing chemical mediators. Repeated insults sensitize the nerves and further increase the pain. So the more pain you have, the more likely you will get pains in the future. The problem is that physical activity might be impacted if you have pain flares, and that might affect the long-term outcome. We found that being barefoot reduces the risk of knee osteoarthritis pain flares, and this is in keeping with previous studies which showed that being barefoot significantly reduces knee loads, reduces knee adduction moment, and reduces the adverse torque on the knee. In addition, being barefoot improves the sensory perception of the foot and improves muscle function. It's very difficult to follow our patients in our setting, and this may be applicable to you. If you have lower limb joint disease, you can't really navigate public transport, bending your knees and climbing into crowded trains and buses. And if you're a daily wage earner, as most of our government sector patients were, they will not come to clinic because of loss of wage. Telephone based was considered important, but patients again have multiple mobile SIMs, connectivity problems, and they are not happy to spend 15-20 minutes with you on the phone. So that again is a challenge for us in South Asia in doing a longitudinal follow-up. Because of the many challenges, we had to develop the prediction model in the Australian cohort. And we used, again, the outcome was knee osteoarthritis pain flares in 30 days, and the predictors were the baseline risks we examined earlier, and we used statistical techniques to develop the model, and we found that the model with age, body mass index, female gender, increased years with knee OA, higher pain scores, more injuries, more buckling, more use of shoes and higher heel heights had a moderate predictive ability and good internal validation. But what was important is that demographic risk factors which increased the risk of knee OA per se did not predict knee OA pain flares. The third part of our research was to identify pain trajectories in early knee OA. We really don't know whether pain is static in early osteoarthritis or whether it progresses in the initial stages. So we use longitudinal latent variable mixture modeling to identify similar patterns of pain evolution in patients, and these patients were statistically grouped to clusters by using longitudinal variable mixture modeling. We use standard model specification terminology, and I don't have time to go through this, but we developed a 3-class latent growth mixture modeling, quadratic model, which showed that the vast majority of patients with early OA don't have a change in pain. A small number do have worsening pain, and these patients were characterized by higher pain scores, higher stress, higher mood, more injuries, and poor quality of life compared to those whose pain was static. So, it's very interesting that the drivers of short-term pain progression are essentially similar to those who have long-term knee OA pain progression. So, the research identified and presented here showed that inflammation is dominant in early knee osteoarthritis, and that risk factors which are both associative and predictor of knee osteopain flares can be identified. Knee buckling, knee injury, increased physical activity, footwear use, and poor mood are associated with increased risk of pain flares, while being barefoot reduces pain flares. And these same risk factors cause progression of pain in early OA. So this is a useful point for us to address in prevention of progression. What does it mean to the clinicians? We can do neuromuscular training, treat effusions to prevent knee buckling. We can improve core stability to reduce injuries and falls. We can promote persons to be barefoot if they are habitually so. And we can give them coping strategies to cope with negative mood. We must also help our patients cope with the short-term pain exacerbations with physical activity so that we can really improve their long-term outcome by engaging in physical activity. We need to prioritize healthcare and prevention for early osteoarthritis without loading our healthcare systems with end-stage osteoarthritis. So, we also believe that larger cohorts from similar countries like ours must be developed to develop early osteoarthritis clinical trials, and especially for knee osteoarthritis, pain flare related endpoints. And we must improve prediction models with low-cost strategies like ultrasound. And we hope that these interventions will minimize the impact of knee osteoarthritis pain flares and prevent the progression of this disease in its early stages so that we don't have to tackle the burden, financial and socio-economic burden of end-stage knee osteoarthritis. Thank you. Thank you.
Thank you, Dr. Hiroshi, for your...
With their pain, but we explored this in multiple models, and it was independently associated with reduced risk of pain flares.
So we'll start on the next session, which is on chronic pains and our practice, so pain clinics of India. So here we have 3 talks, okay. So we will have first Dr. Shyam speaking on science behind yoga, and then we have Dr. Mithun speaking on top papers from India on chronic pain, and we have a guest lecture from Dr. Buchinder for low back pain. And lastly, we'll have a Q&A session. So I will invite Dr. Aparna Reddy, so consultant rheumatologist at Sri Sanvi Oncology and Rheumatology Center, Pispati, and Dr. Bhuvanesh Mahendran, consultant rheumatologist at King's Trivandrum, to chair the session and take it forward from here.
Dr. Shyam is a consultant rheumatologist at Kaveri Hospital in Chennai. He is also the associate editor in Indian Journal of Rheumatology. Over to you, Dr. Shyam.
Followed by a brief systematic review for the evidence. So why are we really discussing fibromyalgia, unlike our other inflammatory arthritis, CTD, vasculitis, which many of us might be more interested clinically? This is the third most common next to back pain and osteoarthritis. The prevalence is somewhere between 2 to 3%. Of course, it varies around the world. It depends on the type of study and the type of criteria used for it. Most important thing is it falls outside the mechanistic definition of a disease. The pathogenesis per se is pretty intriguing. It's mostly clinical diagnosis. We don't have any serological markers. There are no biomarkers. Most important thing is patients, they have very poor quality of life. I think many of us know the difference which we can make to a patient with inflammatory arthritis or SLE is different from what we can make to a patient with fibromyalgia. So nearly 25% of the patients, they stop working once they are diagnosed within the first 5 years. And the healthcare cost, we know the extensive set of investigations they undergo. And we hardly have few FDA indicated drug therapies like duloxetine or meloxicam, and they hardly help in around 20 to 30% of alleviating the symptoms. So this is the prevalence in Asia. It's somewhere between 0.6 to 4%. So we shall briefly look into the clinical spectrum of fibromyalgia, the pathogenesis, so that we understand in what way yoga helps it, and what is the biological evidence for the same, and a systematic review. So the major fibromyalgia symptoms, the cardinal features are generally pain, fatigue, and sleep disturbances. But we do have a lot of other common features like psychiatric symptoms, cognitive dysfunction, autonomic disturbances, regional pain syndrome. So these are some of the things which we can't touch alone only with the pharmacotherapy, where alternative or a complementary medicine also, when it is given along with pharmacological therapy, helps. So these are the things which we should know, because it's not just about pain. So coming to the pathogenic model, we have two things, one which happens in the central nervous system and another in the peripheral nervous system. So in the peripheral nervous system, we have two things. One, what are the nociplastic alterations? In what way the pain stimulus is amplified, and what about the pathogenic mechanisms? So what happens is there is a peripheral sensitization. Many of the times we know that there is evidence that fibromyalgia, there is a small fiber neuropathy or nerve dysfunction is there. So there is increased cytokine threshold, there is more of neuroinflammation, which in turn increases both the peripheral and central sensitization. Then many times there are genetic factors. Many of these patients might have a chronic pain syndrome in the family, or they might have other psychiatric illness like anxiety or depression running in the family. When we come to central nervous system, so there are some parts of the brain where they are functioning more, in the sense the pain threshold comes down. Then there are parts of the brain which ideally should be helping out in anticipatory mechanisms whenever there is a pain. Those areas, they actually function less. Basically, the pain inhibitory signals are not functioning adequately, because one, it can be to do with the inadequacy of neurotransmitters, like the inhibitory neurotransmitters like GABA, which we know helps with the gating mechanism. So those things are in a lesser. This one, similarly, other things like endorphins, so beneficial cytokines are less. Whereas pro-inflammatory, something like one which mediates pain, like glutamate or substance P, those things are like excited neurotransmitters are more. Other than this, it also has it's more like a biopsychosocial model for fibromyalgia. Means there is also a lot of cognitive factors, like how they cope with the pain. They do have a very low resilience, means they are not able to manage or anticipate and react to the pain appropriately. The coping with the pain is not in a good, that's what we call as a maltherapy stress coping. And of course, sleep disturbances, whether it is because of sleep disturbances, these patients have chronic pain, or the other way around. Similarly, one of the most things, not just with regards to inflammatory arthritis, even here there is a dysautonomy. In the sense, usually parasympathetic is more of a anti-inflammatory and sympathetic is inflammatory. So there is a disturbance in the balance. And we also see many other dysautonomia features, like these people have loss of balance, they can have low blood pressure, all those things also. So the role of specifically vagus nerve in fibromyalgia, why I put is so that we know in what way yoga or meditation can help with improving the parasympathetic nerve system activity, or in what way it can help in correcting dysautonomia. So there is a dysfunctional neurotransmitter system, the ones which influence the body's endogenous stress response, and thus came the polyvagal theory. So vagus nerve, as I was referring to, it has a lot of anti-inflammatory properties, both via its afferent and also efferent fibers. And many times in fibromyalgia patients, they found there was a very low vagal tone which was assessed by a very low heart rate variability. So in that way again yoga will be beneficial. So in helping in correcting the dysautonomy. Here what happens is the sympathetic nervous system is persistently active. Though we call it is persistently hyperactive, but it will be at the same time hyperreactive to stress. Because of continuous feedback inhibitory stimulation, it won't be able to respond adequately to stress. Then other than that, these anti-inflammatory and psychological properties of the vagal nerve may possess therapeutic potential in treating fibromyalgia. So this is the inflammatory reflex. So whenever there is inflammation in the periphery, there will be stimuli through the vagus nerve, it goes to the CNS, and from there, there will be inhibitory thing like acetylcholine will bind to its receptor, particularly in the macrophage, and there will be cut down on the production of IL-1, TNF and other inflammatory mediators. Even sympathetic can also help in some way, like glucocorticoids can try to cut down, but mainly the inflammatory stimulus is for the cholinergic anti-inflammatory pathway. That is something which yoga can be beneficial in augmenting this particular cholinergic anti-inflammatory pathway. So coming to the treatment, in diagnosis of fibromyalgia, it's not only about the drug treatment and patient education. So we have 4 pillars. Other than that, we also have psychotherapy and also patient education and fitness. So here in psychotherapy and also about fitness, this is where yoga will be useful. So yoga is basically a multidimensional one. It is an integrated mind-body medicine. Yoga technique is associated with mind-body relaxation. So the 3 basic things, one is about postural exercises for strengthening something like aerobic, what we call asana. Then breathing exercise, pranayama and also meditation. These are the ones which will be taking care of the central sensitization part, and also with regards to the dysautonomy and how it enhances the parasympathetic nervous system. So definitely it is a complementary adjunctive and adjunct medical therapy. So what are the biological evidence for benefits of yoga? Yoga definitely decreases the local and systemic inflammation, decreases the level of oxidative stress. As I told before, GABA neurotransmitter, if it is there, it's an inhibitory one and helps in the gating mechanism. So which is found to be reduced in fibromyalgia, yoga can increase that, and it restores the balance between the parasympathetic and the sympathetic nervous system. And it also enhances the emotional resilience and threshold to pain. Whenever there is no emotional resilience, the patients suffer a lot due to pain. So that part will be taken care, particularly with a modality like yoga. And also it tilts into a favorable cytokine profile, like more of an anti-inflammatory than a pro-inflammatory, because there are various theoretical models for fibromyalgia, and one is persistent neuroinflammation or peripheral inflammation. Similarly, endogenous opioids, there have been studies where they found the number of mu opioid receptors are reduced or they don't function in properly, though the level of opioid levels in CSF was found to be more. Similarly, there are a lot of neurotransmitters like dehydroepiandrosterone sulfate on brain-derived growth factor. These are the things which helps in reducing the sensitization. They help in neuroplasticity. So these things like endorphins, these ones which help in reducing or increasing the emotional resilience or reducing the sensitization to pain, they are increased with yoga. So this is again another diagram which can show what are the mechanisms by which chronic stress happens in fibromyalgia, and how yoga by doing a parasympathetic activation and by decreasing inflammation and by helping with hormonal homeostasis, it actually helps with chronic stress. So it's more than inflammation, it's also more into the cognitive and behavioral aspect. So this is a conceptual model for impact of yoga. So as I was talking about, it is basically helps with regards to cognitive appraisal and personality. In the sense, whenever there is a chronic pain, there is severe disability and interference. When something is able to cut off that disability or interference, that is called pain resilience. So yoga helps with pain resilience. So pain resilience is more of a positive factor. There are other negative factors like psychological distress, pain related, like psychological distress, something like a catastrophe. In the sense there is an exaggerated pain response. They feel emotionally also they feel very low, these patients. So those times are negative behaviors. Similarly, pain related substance abuse or alcohol abuse can be there. So those things are negative. Whereas a yoga can, what it can do is it can increase the pain resilience and make sure the pain doesn't cause us a life interference. So going into the systematic review, so I really should have been with the people, but I have done it myself with regard to the bias, but I am copying. So coming to the search method, these are the this one databases of the search, and only randomized control trials were included in want of time. Of course, there are around 8 to 10 more observational studies in the case report. So participants, all adults who satisfied either the previous fibromyalgia criteria or the newer one are included. So anybody who underwent a yoga intervention along with the comparator arm, sometimes active intervention was there, sometimes there was no active treatment was there. Outcome, whether primary outcome measures like pain function or any of the secondary outcome measures were included, and risk of bias was assessed with the cooperating factor group 2. So these were the number of articles which are screened, and around 6 randomized control was chosen in the end. So the trial one initially was done by De Silva et al. So here many of the trials were before 2010, so the criteria used was around the 1990 ACR criteria. It was a small sample size of 40. So 2 arms, relaxing yoga and one with relaxing yoga plus touch. So these are the 2 arms. So in what they found is the outcome was assessed at the baseline, then after 8 weeks, then again after another 4 to 6 weeks. So both the groups did well. So relaxing yoga and also the plus touch. Plus touch means there was, along with that, massages was also given at the end of every session. So though the reduction in pain severity was better, but the arm with yoga, they had a long lasting, even after the sessions were over, after 8 weeks also, these people did well. Even, they were of course asked to practice at home the same intervention, but what they found is the effect was long lasting even after the trial period was over. Of course it was a very short duration. So definitely this was a positive trial, though the bias risk was high in that. The next trial, this was based on something called mind-based stress reduction technique. So it includes skills like sitting meditation, hatha yoga, and a somatically focused technique called the body scan. It is about realization of one's own self, how we perceive pain, how we adapt to it, something like that. The sample size was pretty good. Again, it was a very small, this one only a 8-week study. The bias risk was low. So what they found is, the conclusion was depressive symptoms did significantly improve in the treatment group versus the control group. So this was a positive trial. Then there was one more based on the same technique. Here there are, one was an active group, another was a wait-listed group. In the sense, once the trial is over, they will be changed over, and again these people also will be getting the same modality of treatment. So here, this was not a positive. They couldn't, the primary outcome measure was not satisfied. Though they did some post-hoc analysis and found some numerical difference was there, but it was not statistically significant. So one trial did favor, the other one didn't, was not a positive, this what you call trial. So then this was another trial where again an 8-week group. Most of the trials are very short duration because there are practical difficulties in making these patients to be inclined to take part in the trial. So again it was an 8-week group thing. So this type of yoga was called yoga of awareness. So it had all the components like stretching, which is more like postural exercises, breathing, then mindful meditation, optimal coping, and group discussion. These are the 2 things which are extra in the yoga of awareness. How they are able to cope up, and there was a group discussion explaining to the patients what was done in what way it is going to help the disease. So the risk of bias was low. So this was a pilot study. So there was an active group and then there was a wait-listed group. So they found that definitely yoga did help in all the parameters in both primary and secondary outcome. The same study was again that the wait-listed group was then got the active intervention and they found the same results. So initially it was the wait-listed group didn't get anything. Then after a period of 12 weeks, 8 weeks plus a gap of 4 weeks, the wait-listed group got the active intervention and the effect was same. And even the group who finished the therapy, they also had a persistent benefit was found in that group also. So So this is the last trial. Here this was based on aquatic respiratory exercise, but this phenomenon was based on yoga, like how they do meditation and the pranayama. So this was included in the one of the trial in the systematic review. Again, this was a positive one. So definitely a short-term aquatic respiratory exercise-based program improved the pain, quality of life, and the functional capacity, and all the other secondary outcome measure. So all these were very small trials. Most of them were white Caucasian females who were well educated, who had a lot of inclination to take part in these programs. So this is something with it's an ongoing trial. And other thing with the previous trials was there was no active comparator group. So here it was yoga versus a structured exercise program. And the other advantage with this, there are very significant numbers, around 120 odd in each group, one in the yoga and the structured exercise program. And most of them are elderly people, and almost 2/3 were males, unlike females in the previous trials. So, and it's for a period of 12 weeks and a follow-up 9 months. So maybe the result comes, this is a properly designed study. So it might be more beneficial, or we might get a better data with this. So coming to the take-home messages, fibromyalgia, there are various pathogenetic models. It's not one single thing. So there are various arms of treatment, as I told about the psychological part or the cognitive part, which is very difficult to tackle. So yoga definitely helps. In what way it helps is, one, it helps in acceptance of the pain, how people are willing to learn from the pain. Definitely decreases the emotional distress, because pain is not just the phenomenon of pain, it is more than that. There is a lot of emotional component to it, and definitely it helps in dysautonomia, like increases the parasympathetic and reduces the sympathetic activation. Similar to exercise, it also helps in improving the physical and mental strategies. It has a positive bearing on autonomic dysregulation, as I told, more on vagal this one. Of course, it improves strength and balance. So all the trials, whatever we discussed, they are of small sample size, shorter duration, biased population because of the willingness of people to participate in it, and there are no valid control arms. Definitely there is an evidence for yoga being beneficial in fibromyalgia, particularly with the multifaceted phase. Of course, we need with long-term studies, and we have to find out which individual component of yoga is helping, because yoga has asanas where we do something like an exercise where there is muscle strengthening, whether it is that part which is helping, or whether it is the breathing part which helps with parasympathetic like pranayama, or whether it's a meditation part which helps in coping up with the pain. So this individual components also have to be studied to really tell which component of yoga is beneficial, otherwise or it's going to be just like an aerobic exercise, or in what way it can be different from a cognitive behavioral therapy. Thank you.
Presenting on the top papers from India on chronic pain during 2021-22. Chronic pain is defined as any pain that lasts over 3 months, and chronic pain can be caused by diverse conditions. It can include cancer pain, orthopedic pain, post-traumatic pain. The chronic conditions which are relevant to a rheumatologist include fibromyalgia, hypermobile joint syndrome, CRPS, plantar fasciitis. I have included only the studies on fibromyalgia in this presentation because that is the most common thing we encounter in our clinical practice, and when I search in the literature, there is not much studies on other chronic pains. And how I used a simple strategy for screening for article, PubMed, Scopus, and Google Scholar for complete. And for coming to the first paper, as Sham told, there is evidence for inflammatory pathology in fibromyalgia. Previously, it was conventionally thought that fibromyalgia is a non-inflammatory condition. Now there is evidence that there is inflammatory cytokines are elevated in fibromyalgia. This study is done in our institute, in our Institute of Medical Science, and we actually looked into the levels of IL-6, IL-8, and IL-1 receptor antagonist levels, and it compared with the correlation with the disease severity in fibromyalgia patients. Why we selected these three cytokines? Because a systematic review done on West Indian population, they showed that these three cytokines were elevated in fibromyalgia patients. And this is a single center study, and the outcome measures used to measure the disease activity in fibromyalgia include VAS pain, FAQR, brief pain inventory, pain scores, SF-36 health survey. And in the study, what we found that IL-1 receptor antagonist levels significantly lower in fibromyalgia patients, whereas IL-8 and IL-6 levels were not, there was no statistical difference between the fibromyalgia and control patients. This was in contrast to the Western population studies where all the three cytokines were lower. And in conclusion, we can say that these Indian patients may be genetically diverse from or different from the Western population. At the same time, we should also know that the depression, which is a closely related disease disorder to fibromyalgia, in depression also there was shown that cytokines levels were like IL-6 was high in depressive patients. But in Indian study that showed that IL-6 levels are not high in depression. Therefore, there can be a genetic variation in our population. And the next study actually based on the secondary fibromyalgia, the effect of secondary fibromyalgia in other inflammatory conditions cannot be overlooked. This study is from PGI Chandigarh. They actually looked in the effect of fibromyalgia in the quality of life and the disease activity measures in psoriatic arthritis. The health-related quality was measured using PROMIS HAQ, pain, HAQ, health and FAQR. And disease activity measures include the swollen joint count, tender joint count, VAS day, enthesitis, dactylitis, PASI. And PROMIS HAQ correlated with the measures of FMS, which include FAQR, SSS score, white pain index score. And out of 102 patients, 18% had secondary fibromyalgia. And patients with PSA and fibromyalgia had significantly higher level of disease activity in the form of higher tender joint counts, swollen joint counts, and enthesitis. But there is no difference in the dactylitis and the psoriatic skin disease. And there is a significant positive correlation of measures of fibromyalgia with the psoriatic arthritis disease activity measures. And health quality was also significantly worse in those psoriatic arthritis patients with secondary fibromyalgia. The take-home message from this study is that secondary fibromyalgia is an important contributor towards a poor quality of life in patients with psoriatic arthritis, and it also is associated with higher values of joint disease activity measures. Therefore, this fibromyalgia component of psoriatic arthritis should be addressed properly to attain a proper disease control. Another paper is on an important concept of fibromyalgia. It's called invalidation in fibromyalgia. It's otherwise called discounting or lack of understanding. Discounting, in other words, simple terms, we call underestimate the symptoms. This is usually done by the spouse or the close relatives and even by the medical professionals. And the lack of understanding. Even if patient says pain, patient, even spouse may not understand. Sometimes doctors also may not view, or that's called empathy, lack of empathy. This study is done in the Government Medical College of Jammu and Kashmir. Here, what they looked is they look for invalidation in fibromyalgia and RA Indian patients, and their correlation look for the correlation between the invalidation and the quality of life. The invalidation was measured using a questionnaire called Illness Invalidation Inventory. They look for the discounting and lack of understanding across sources, that is spouse, family, medical professionals, and work environment. And the quality of life was measured using WHO quality of life questionnaire. And 55 fibromyalgia and 102 RA patients were included in the study. Compared to rheumatoid arthritis, fibromyalgia patients significantly had a higher discounting by the spouse, family, and medical professionals. Also, the fibromyalgia patients suffered more lack of understanding from the spouse and medical professional as compared to RA patients. In fibromyalgia, discounting by the spouse and the medical professional had a weak to moderate negative correlation with the quality of life. And in conclusion, fibromyalgia patients face more invalidation as compared to RA patients. Because this is very important, because the empathy towards this patient and the time to spend to hear their concerns is very important, because that if you don't do that, we may not get a good relief or good response in fibromyalgia patients. Coming to the next study is based on the pharmacology treatment of fibromyalgia. And the drug which is used in fibromyalgia depends upon the treating physician's discretions. And most commonly drugs used is the duloxetine, pregabalin, amitriptyline, mirtazapine. In this study done in the Kalinga Institute of Medical Science, Bhubaneswar, they tried to see the how mirtazapine is effect and adverse effect compared to duloxetine in treating fibromyalgia patients. Here they looked into the medical records to identify patients diagnosed with fibromyalgia and who were on duloxetine and mirtazapine for at least 6 months. And the present status was determined using a telephonic interview, which included a Likert scale out of 1 to 5 and FAQR and adverse effects and complaints. 150 patients were screened and 81 patients were included. And out of 79% had primary fibromyalgia, rest had secondary fibromyalgia. And 81% of the patients were on duloxetine, and only 15 patients were on mirtazapine. That can be understood because mirtazapine is not commonly used. And overall, a moderate to good improvement was seen in approximately 81% of the patients. And if you see the separated groups, duloxetine group had a good improvement when compared to the mirtazapine group. And adverse effects was lesser in the duloxetine group, and mirtazapine has a poorer complaints. And in multivariate analysis also, duloxetine use was associated with better subjective outcomes. And at least we can say that in this study, it appears that duloxetine is found to be better than mirtazapine. Therefore, mirtazapine may not be used as a first line in treating fibromyalgia patients. And we cannot ignore the importance of psychiatrists and psychologists in the management of fibromyalgia. And this paper is also from our institute. Actually, we use the affective cognitive behavior therapy and to compare it with the Jacobson progressive muscular relaxation, we call JPMR, to see its effect in the managing fibromyalgia patients. Patients receiving the CBT and the JPMR were allocated into 2 groups. It is a small size sample size, 10 each. And baseline assessment was due to pain and fibromyalgia impact prior to fibromyalgia impact using FAQR. And post follow-up was done 1 week and 1 month after the intervention respectively. And then the post scores of both groups were compared. This study, the criteria for improvement says 30% reduction in pain in BPA scale after the completion of intervention is considered as improvement. And the result of the study is that affective cognitive behavioral therapy is associated with impressive improvements in the pain reduction and FAQR when compared to the JPMR. And we can say that the take-home message is that CBT, cognitive behavioral therapy, especially the affective cognitive behavioral therapy, is a modification of the advanced CBT, can be used as an adjunct to the pharmacological treatment for better outcome in fibromyalgia. Next is about the comorbidity of in fibromyalgia. Like in other inflammatory conditions, usually the comorbidities are usually overlooked. And it is recently well known that inflammatory conditions are associated with accelerated atherosclerosis and increased cardiovascular risk. And what about fibromyalgia? This study done in our institute, actually we looked into the cardiovascular risk score using a traditional case control methodology and also using a novel machine learning technique. Firstly, we divided the fibromyalgia cases into 3 categories, one between 18 to 39 age group, one is between 40 to 59 age group, and the third group is more than 60 years. And a 10-year lifetime CVD risk was calculated in both cases and controls using a atherosclerotic cardiovascular disease risk calculator, which is a device proposed by the American Heart Association. And it has advantage of the Framingham risk score because it can be used in all ethnicities. And secondly, we use the machine learning predictive models of cardiovascular risk in fibromyalgia patients. A random forest algorithm was used to develop the predictive models with a cardiovascular risk of 10 years and lifetime risk as target measures. And we had a total of 139 fibromyalgia patients, and there's a healthy control of 1,820 controls. This healthy control data was taken from another study done in our own institute. And the fibromyalgia patients in the the study showed that in the age group of 40 to 59 years, there is an increased lifetime cardiovascular risk when compared to the control group. And the machine learning model also had a good accuracy in predicting the same. In addition to predicting the high group cardiovascular risk in this 40 to 59 middle-age group, the fibromyalgia disease severity parameters were also important contributors in the machine learning predictive models. The take-home thing from this study is that there is an increased risk of cardiovascular risk in middle-aged females, especially middle-aged females in fibromyalgia patients. And machine learning is coming to be a big thing in future. Likely we are going to see more studies on machine learning, and they're used to some things which are not picked up by standard conventional statistical methods, were picked up by the machine learning techniques. And coming to summarizing my talk, I could not find much studies on chronic pain from India at least in the last 2 years. And what I think that fibromyalgia and the chronic pain syndromes are ignored when coming to research. And there's a huge scope for high quality research in fibromyalgia in Indian center. Thank you for your patience.
Thank you, Dr. We have a guest lecture by Dr. Rachel Vishwendra. She'll be talking on evidence-based care for low back pain. She is a professor at Monash University Department of Epidemiology and Preventive Medicine, an Australian National Health and Medical Research Council investigator fellow.
Thank you for inviting me to speak at the Indian Rheumatology Conference. I'm going to talk about evidence care for low back pain. These are my declarations of interest. I'm a rheumatologist and coordinating editor of Cochrane Musculoskeletal Back and Neck, and also chair of the Australia and New Zealand Musculoskeletal Clinical Trial Network. That was really a call to action, because we believe that much of the problem of disability for back pain is due to low value care. I led the series, and it involved 31 authors from 12 different countries. The call to action was to address this epidemic of poor care. The main problems, as we saw it, were widespread misconceptions among both consumers and clinicians, deeply embedded culture that is resistant to demedicalising back pain, vested interests in funding arrangements that reinforce the wrong care and discourage the right care, and fragmented and outdated models of care. So this epidemic of useless and often harmful care is a problem globally, and over time it's likely to increase in lower and middle income countries. This slide gives us some examples from India. So the first study found that almost half of the physiotherapists in this region of India would advise patients with low back pain to rest. Another study found that 63% of the general population believe that med rest is also a mainstay of treatment for back pain, but this is not the case. In a third study, all patients who had been seen in an orthopaedic clinic for chronic low back pain received imaging, even though the diagnosis in over 3/4 was non-specific back pain, and probably over 86% of another 10% was due to spondylosis. Similarly, in the same study as the first one, a third of physiotherapists would use what we know to be physical modalities that have been proven not to work as first-line therapy. So turning now to one of the most harmful misconceptions, that there is a specific cause which we can identify, and therefore that the most appropriate treatment could be given and the patient can be cured. Part of the problem is that we have new and more sensitive imaging modalities, and therefore we're likely to pick up many abnormalities that increase with age, but are likely not to explain the patient's pain. We know that over 50% of patients believe that imaging is necessary to get the best care for back pain. And we also know that about a third or more GPs also believe that X-rays are useful in the workup of someone who presents with acute back pain. Yet we know that in primary care, serious causes are rare. This is an Australian study where only 1% had a specific cause. It is likely to be higher in India due to things like tuberculosis. We know also that while there's a link between symptoms and structural changes, many asymptomatic people also have these changes. These asymptomatic abnormalities increase with age, and we now know both from plain X-ray and MRI studies that these degenerative changes do not have clinically important associations with either current back pain or future back pain. The graph here shows that for findings such as loss of disc height and degeneration, there's no relationship with current or future back pain, and the same for all of those terms listed on this slide. So detecting them might cause more harm than good. This is an old study now, but it was the trial where patients were randomised to either get an X-ray or MRI at baseline when they presented with acute back pain. And what you can see is at the end of 12 months, back pain disability was similar in both groups, but people who had the MRI, the more sensitive scan, were much more likely to have received surgery. We also know that imaging increases medical costs, healthcare utilisation, and results in more absence for work. This is a systematic review of all the studies that have been published looking at the rates of imaging in both primary care and emergency care. And it indicates that even currently, 1 in 4 people in primary care get imaged, and 1 in 3 people in the emergency department get an image. Furthermore, complex imaging, that is CTs and MRIs, have increased relatively by 50% over the last decade. We also know that this is an internet survey from one of our studies, finding that the public poorly understand these common imaging findings. The majority think that these terms are likely to be serious and therefore likely that the pain will persist and that they'll be fearful to move. People with more education and more positive or better beliefs about back pain were less concerned. We also know that more complex imaging like MRI and CT scans, as indicated here, have a much higher carbon footprint than imaging such as chest X-ray and ultrasound. And down the bottom here I put in that one MRI scan is equivalent to driving a new European car 145 kilometres, or a CT 76 kilometres. And this compares to a chest X-ray of 6 or ultrasound of 4 kilometres. So not only are we harming patients, increasing costs, but we're also harming the planet by these more complex tests. In an update to the Lancet series, we published more information about calls to action in pain in 2020. And in this paper we highlighted the problems that we see in terms of drug therapy for back pain, and I'm going to go through a couple of these now. So we know about the opioid epidemic in developed countries like the US, Canada, Australia, the UK, but this paper in the Los Angeles Times made clear that there was that far from this US epidemic, the other opioid crisis was raging in vulnerable countries, including India. And this has been brought about by the use of tramadol. Grunenthal, who made tramadol, also made the wonder drug thalidomide. And this company continues to maintain that the drug is safe, even though there is now overwhelming evidence that it has similar addictive properties to opioids. And a loophole in international regulation has meant that this drug can be sold quite freely in developing countries. There is also a problem of counterfeit pills, and the Los Angeles Times claimed that the funds from selling tramadol has also funded terrorism. Yet what we know is that opioids, this is a systematic review looking at chronic pain, which includes about 2/3 of the studies were people with back pain. And what it shows is that for chronic pain, opioids actually do not improve pain to a significant degree. The mean benefit over placebo was less than 1 point out of 10. And you can see the mean difference was minus 0.69 out of 10, which is not considered to be a clinically important benefit. So not only do we have these problems with opioid epidemics, they don't work terribly well for people with back pain. Yet, from the same study, there is a 2.5 to 4 times greater incidence of vomiting, as well as these other side effects here. So not only do they not work, they cause harms, and these are the short-term harms demonstrated in the trials and the long-term harms that I've already alluded to. We don't think that medicinal cannabis is going to be the answer. This is another systematic review that I was part of, published in the BMJ, to go alongside the guidelines, the international guidelines. And again, this was looking at chronic pain, and there was one study for back pain. And again, we found that the mean benefit over placebo was likely to be small and likely of no importance. So I don't think this is going to be any dramatic breakthrough treatment for back pain. And from the same study, there is a much higher risk of dizziness and moderate certain evidence that it also causes transient cognitive impairment, as well as vomiting, drowsiness, impaired attention and nausea. So again, the harms may outweigh any benefit. We know from a large trial that was performed in Australia that paracetamol has no benefit over placebo. And I don't know whether this is used in India, but it's certainly increasingly used in Australia. And these are the gabapentinoids, so Lyrica in our country, or pregabalin and gabapentin. We know that these drugs are increasingly used around the world. Yet a systematic review based on 3 trials shows that these drugs do not improve people with back pain, and they also do not improve people with radicular pain. Yet from the trial data, there's a 1.4 times increased risk of adverse effects. So again, this is another group of drugs where the risks outweigh any benefits. Not only that, but there is an increased risk of death in people who take a combination of pregabalin and opioids, particularly higher doses of pregabalin. We know that non-steroidal anti-inflammatory drugs are only modestly effective, but they do have potential for harm, and so care needs to be taken when prescribing these in people who are at risk of adverse effects. And you can see here that they do have a benefit, which is quite modest. Moving now to antidepressants, this is a systematic review from last year, and basically found that there were no benefits from most classes of antidepressants. There was a small but probably unimportant benefit from the SNRIs only. Similarly, for sciatica, there was very uncertain evidence that was based on a few studies that had methodological problems. So we're really uncertain whether this may help people with radicular pain. And similar to the other drugs, there is evidence of increased risk of adverse events, and these drugs cause dizziness and sedation and may increase the risk of falling, particularly in older people. Skeletal muscle relaxants from another systematic review again found small and likely clinically unimportant benefits. And again, potential for significant harm. So moving off drugs, so unfortunately drugs aren't really the answer for people with back pain. There was a recent trial published only a couple of weeks ago showing that spinal cord stimulation compared to placebo did improve back pain related disability, as shown here in this graph. And we recently published a study looking at spinal cord stimulators that had been reported to our Therapeutic Goods Administration to have had an adverse event. And what we found was that for every 100 implanted, about 40 needed to be removed. And you can see that the types of reasons for its removal there. So again, this is another treatment that's likely of no or little benefit, but a significant risk of harm. And these are also very costly. And finally, I just wanted to note fusion. We know there's a large practice variation, and increasingly instrumented fusion is being used for so-called instability. Fusion's associated with increased blood loss, longer surgery time and greater costs, and the available evidence does not support its use for most types of back pain. Of note, this was a New England Journal Medicine paper published last year that compared decompression with or without fusion, and found that decompression alone is not inferior to decompression and fusion, and therefore this supports what I said in the previous slide, that fusion should no longer be offered to patients. What remains unknown is whether decompression itself is of any value, and we're actually doing a placebo-controlled trial at this moment for people with spinal canal stenosis. So finally, I wanted to just put up these proposed actions to improve care for back pain that we published in the update to the Lancet series, but also lots of proposals for action in the old one. And I'm pleased to report that some of our proposed actions have been followed up. So for example, in Australia, just published are clinical care standards that provide what quality care patients should expect to receive, and this is written for both patients and clinicians. And I'm currently on the working group for the WHO guideline on the management of chronic primary low back pain in adults. And so that we did suggest to the WHO that they develop international guidance as well, and that's in progress. So thanks very much for listening. This is the links to the Lancet series in my email if you have any questions that we don't have time for today. Thanks very much.
One or more, and been through the whole armamentarium, still attending pain clinics. But there are things that the pain clinics do which you didn't make any reference to. Interventions like injecting for cerebral joints once you think you've identified the source of pain. But when patients reach the end of their tether, they are really desperate. And I'm not sure that anything that you've suggested offers them any comfort. One of the advantages of further investigation of those patients is that you reassure them they don't have cancer or some other awful disease. And I think that helps to treat them or treat their psychological problems which usually accompany chronic low back pain. But thanks very much. You've opened a can of worms, really. A lot more to discuss about how we should be managing these patients.
Thank you. Bizarre to try and change that. And the other thing that some places are setting up a physiotherapy, that they see the physiotherapist first and then they get an appointment the following day. So we're trying to shortcut the problem of chronicity by treating them appropriately in the first instance. And we know that actually imaging some clinicians think that it does reduce anxiety, but in many patients it increases anxiety. because of the terms that are used.
Thank you for the amazing talk, madam. I have a question for you. Am I audible? My question is, what type of physical exercise do you advise the patients for chronic back pain? And another question is that, is there a role of diathermy or heat therapies that are being given in chronic back pain?
So the first question is that exercise, I mean, by the time they get to me as a rheumatologist, they've often had lots of different opinions and advice, but I try and work out what they do currently, what they enjoy doing, and I don't really care what form of exercise that they do as long as they're doing something. And I obviously promote graded exercise and a mix of both aerobic exercise and physiotherapy or another type of exercise specialist, graded core strengthening and back strengthening. Although the evidence for that also is that it may not provide a big benefit, but I really want people to exercise and stop being fearful of movement, because the natural history is that most people will get better. And so I think it's really important early on to address misconceptions that they have about their likely future life with back pain, and misconceptions about what the imaging findings mean, because they've often had imaging by the time they see me, and just to really support them in self-management, making sure they're physically active, even if they have to modify their activities. And if I get them early, I want them to continue what they're normally doing as much as possible. And importantly, staying at work, because there's some evidence that staying at work confers a better outcome as well. In terms of your second question, it's unfortunately the studies for heat and cold, and you can't blind people. That's something that you can't blind, but there is some evidence to suggest that heat may be beneficial.